Respected seniors, my dear friends and colleagues. First of all, I would like to thank the organizing committee, especially Dr. Ramesh sir, for giving this opportunity. So, this is a video presentation for the safety tips in robotic donor hepatectomy. Before going to the details, we started our program 2019. Till April, we have done 421 robotic donor hepatectomy out of more than 4,500 liver transplant. And this is the journey. 2019 we have done 5, and the last year we have done 152 cases, and now 60% of our donor program is done robotically. In our center, the cost difference is 4 lakhs. For the robotic donor hepatectomy, the patient has to pay 4 lakhs extra. The usual cost for the transplant is 21 lakhs.
Fysal, any conversion?
We had conversion in the early period, and we had converted 10 cases out of 420. And the last 2 years there was no conversion.
No conversion at all. So for a biliary anatomy, rarely there is a biliary anatomy when left duct is joining to the anterior sectoral, anterior sectoral or to the anterior duct. We don't have a cholangiogram also. Do you look specifically these things in the MR? And if you doubt such a thing, and it's not clear during intraoperation.
So,
I mean, not anterior going to the left. Is there a left duct? Segment 2 usually or rarely could come on joining the anterior sectoral or anterior duct. That I had seen during open days and also in laparoscopic days also.
So for open cases, we usually never do MRCP. For the robotic, we always do the MRCP. And with the MRCP is our good quality technique. I mean, the radiologist is having good experience. So usually she will tell all the anatomy properly. So even if that case also, we proceed with robot only. Because in robot, another advantage is ICG. So you can clearly see the ductal variation in the ICG.
Yeah.
Most of the cases we have done right lobe, and about the conversion I already told. So the position and the port placement, the 4 robotic arms and 1 laparoscopic arm. And usually with 20-degree head up and 20-degree right side up. Right lobe mobilization is in a retraction technique. Here we need to correctly delineate the RHV MHV junction, and we dissect it properly. And retraction of the right lobe through the gallbladder needs to be retracted with the laparoscopic, and the robotic arms retracted in a constant and continuous retraction. And with that, the right triangular ligament is being taken. During this time, we need to retract the left side with both the gallbladder retraction and the robotic arms. IVC dissection, the small right inferior hepatic veins we need to take with either with hemlock. Sometimes if it is small, then we can take with the harmonic as well. The hepatocaval ligament we have to take with either with bipolar forceps or with harmonic. We need to isolate the RHV properly so that we can pass the silicone catheter for the later hanging manner. And if it is a large inferiors, we need to properly dissect it and loop it. And it needs to be loop. The passing of the silicone catheter should be behind the RHV and RHV. The cholecystectomy part is the usual thing that there is just to divide the cystic duct and cystic artery. And in type A portal vein, where there is only single portal vein. So here we need to retract the cystic duct towards the left, and always there will be a caudate vein. This caudate vein usually take with bipolar, sometimes with the harmonic, sometimes with the suture technique. So dissect this single portal, right portal vein and loop it, and then this looping is important to clamp for the time of the transaction. In type C portal vein, Sometimes in type C portal vein, there will be two portal veins, anterior and posterior. Sometimes you can loop it together. Sometimes you may not be looped the anterior portal vein if it is in the higher. Here we can loop in the anterior and posterior portal vein together, and we need to dissect anterior portal vein and posterior portal vein separately. So it is easy if we can do it, first do it fully, then individually loop. You can see the right hepatic artery being dissected fully, and this individual looping is important to get transection marking after clamping these two things. And also it is important to mark the biliary confluence, the right and left hepatic confluence for the transection purpose. Sometimes this is an Xenopneuma type C where anterior and posterior portal vein is too far apart. This is a rare anatomy where there is RHD, LHD is far below in the extrahepatic space. Here we are. Here I am trying to loop the posterior one. The posterior one I loop, but it was not possible to loop the anterior one. So I am looping the main portal vein here. And this is a rare anatomy where the cystic duct is inserted into the right hepatic duct, and both right hepatic, left hepatic duct being looped, and right hepatic artery is being dissected, and it's prepared for the clamping, and left hepatic duct is being looped so that we can loop the right hepatic duct, and both this right and left hepatic duct being retracted to the left side so that we can clamp the MPV. Clamping of the main portal vein and the right hepatic artery will give a clear transection line. At this time we inject the ICG, we will get a clear transection line. Here I didn't clamp the anterior or posterior portal vein. So then the biliary confluence is marked, and then traction switches being placed, and the parenchymal transection. In the parenchymal transection we use QSA. For all the 421 cases we use the QSA, the harmonic. So in the harmonic, the advantage of the harmonic is less blood loss. Even though the learning curve for the harmonic transection is longer, once it achieved, it is very hemostatic. You will lose only 50 to 80 ml of blood in all the donor hepatectomy. And here it is the segment 5 veins which is being clipped, and always we put a safety clip in the remnant side after the hemlock in order to keep that clip safe, hemlock clip safe. So bit by bit of parenchymal transection is being done with the harmonic, and we use QSA only at the to define the hilar plate, and the pre-placed vital suture is being taken, and the silicone catheter is being taken through to complete the hanging maneuver. And here we need to see the segment 8 veins, and segment 8 veins also we divide as we divide the segment 5 vein. Here we use the hemlock clip, and then safety clip, and the division of the segment 8 vein. This is a small segment 8 vein. We just divide it. We will not include into the recon part, and the hanging maneuver is completed by this. Arch division and vascular division. Here we can see that here this is an extremely rare case where the RHD is so extrahepatic. We loop the anterior portal vein, which we were not done in early because it was not possible at that time. So you can see the right hepatic duct which is being clipped with the hemlock and safety clip, and cut the duct, and that pre-placed the vital thread is being taken through loop the hilar plate. Usually we take the hilar plate in a single go, but here the hilar plate is so wide and thick, so we are taking in 2 goes, taking the hilar plate, and hilar plate also we divide in between the clips. Here, as it is a bloody area, so we temporarily clamp the RHA, and then you will get a clear field. Then again the completing the hilar plate dissection. So the division of the and completion of the hilar plate is being done. Usual technique is triple C technique for the hepatic duct division, and the previous one is the very rare anatomy. This is the normal type. This is A3 duct, where you can, this is the way which we usually do the duct cutting. Triple C technique, we loop the RHD, RHD and RPHD together. Then you can see the left hepatic duct in ICG here very clearly. So you can have a very good clipping near the LHD, then the safety clip. Always we do RHA clamping, so clip, clamp, and then cut. That is the triple C technique. And RHD or RPHD, you can see the two openings here. This is a type A3 anatomy, so obviously we are expecting the same. So the pre-placed vital switch is done to hilar plate hanging, then hilar plate division is being done. Vascular division and graft extraction, bagging of the specimen, then the graft, then the RHA clipping is done, and the division. And in the portal vein division, we usually use the hemlock with a safety clip and a clip in the graft side. So earlier we used stapler, but we found that there is a loss of portal vein length in the graft side. So this is we have done for more than 370 cases, and it is time tested. Thank you.